So moving on to our next talk by Dr. Mudit Tyagi, who is again a senior retina and a uvea consultant at LV Prasad Eye Institute, Hyderabad. And Dr. Mudit is also very passionate about endoscopic vitrectomy, and he would be sharing his experience of performing that in uveitis patients.
All right. So good afternoon, and first of all, let me thank Dr. Manisha ma'am for having me as a part of this IC and to AIOC Scientific Committee. And can I please have my slides? Yeah, so I'll be talking about the role of endoscopic vitrectomy in uveitis. Now we all know that in retinal surgeries, what we need for doing any surgery is a good clear media. In the absence of clear media, whether it is because of a corneal opacity or because of synechia or because of cataract formation, our ability to do a vitrectomy or any retinal intervention becomes compromised because of the fact that now we can't visualize what's happening inside the eye. Now what endoscopy does is that because of the fact that it's got a inbuilt camera incorporated into it, it allows us for visualization of what's happening inside, obviating the problems caused by an opaque media. And I'll show you how they can actually be beneficial even in uveitic eyes. So if we look at it, the first ocular endoscope was developed way back in 1934, but the modern endoscopes that we use were developed in 1990, followed by 23 gauge systems in 2011. Now this is how an endoscopy system looks like. If you look over here, you have got a system over here which has got a built-in light source. It has got a camera which is built in with it, as a fiber optic cable which is fused into a 1923 or a 25 gauge micro probe. So it's got a light probe, an image acquisition fiber optic cable, and also a laser inbuilt into it. This is how it actually looks like. So it takes a bit of a learning curve, because now instead of looking into your microscope, you're looking at a screen in front of you, and that screen visualization takes slight learning. But once you have overcome that initial very minimal learning curve, you will be able to navigate most of your way. So this is what I mean. When you do a vitrectomy conventionally through conventional viewing systems, you've got a bird's eye view. So you're able to visualize from top what's happening over here. An endoscope, because of the fact that you're putting a light pipe inside, you only have an end-on view where you visualize whatever your endoscope is focusing upon. The good part is that even with an endoscope, we get a view of around 50 degrees in a fluid-filled eye and around 70 degrees in an air-filled globe. Now, how does it help in uveitic eyes? Now, the first point is that in a lot of these eyes, because of synechia and ciliary body membranes, there may be a problem in the placement of our cannulas. And endoscopy helps in assessing the position of the cannula, whether it's subretinal, occasionally subchoroidal, or what's happening in the subciliary areas. So you can visualize with the help of a probe what's happening to your cutters, what's happening to your infusion cannulas. You can visualize your ciliary bodies, so that's where its importance lies. And when you have to measure it from the center of an optical cylinder in eyes with keratoprosthesis, what you need to do is that you need to capture it, and you are able to now visualize what's happening over here in the ciliary body. These are eyes which have got already a migration of the pars plicatus and ciliary bodies anteriorly because of the membranes which are contracting, and putting just an infusion cannula otherwise can be disastrous. But an endoscopic visualization allows you to visualize your sclerotomy sites also very nicely. So like I said, what are the indications? Difficult to access sites like ciliary sulcus, sclerotomy sites, ciliary body, and the area behind iris, and that is where its importance lies in practice of uveitis. So coming on, what are the absolute indications or the role that endoscopy plays in a uveitic practice? And that can be both diagnostic as well as interventional. Now in terms of diagnostic, it helps us in visualizing and prognosticating as to what is happening inside eyes where you have got a posterior segment pathology which you need to assess, but you are not able to do that because of an absence of a corneal opacification like what you will probably see in this eye. Or for that matter, this is an image from one of our publications, but these are the eyes with a failed graft, a keratoprosthesis. And while an ultrasound will just show you an attached retina, an endoscope helps us in assessing what's happening inside the eye in terms of the fact that this is an eye which has got an absolute glaucomatous optic atrophy with a pale disc and sclerosed vessels. So in few of our uveitic eyes with long-standing hypotony, also before going ahead with any subsequent intervention, what we did was we did a diagnostic endoscopy to assess the status of the optic disc and the macula before going ahead with any subsequent future interventions. So what an endoscopy allows in these cases is that it gives us a chance to prognosticate and understand what happens inside the eye. So like this was an eye with a total corneal opacity over here. once you go inside the eye, what you find is a total pale disc with extensive scarring at a macula. So these are eyes which will probably not benefit with a future intervention. So you probably can then explain to your patient a poor adverse outcome which will be expected in these eyes, instead of going ahead with a intervention in terms of probably a transplant or any other future interventions in these eyes. Again, this was another eye with a corneal opacity, but if you compare it with the previous eye, now you see a healthy disc with a good neuroretinal rim, attached retina with a good macula, and these are eyes which probably will do good. This eye actually subsequently underwent a corneal transplant also. So that was the role of endoscopy in diagnosing or in prognosticating. But how can it help us in terms of interventional approaches? So in terms of intervention, what it does is it allows us a visualization of what's happening to ciliary bodies, and one of the most common causes of hypotony in these eyes are ciliary body membranes. So it allows us an assessment of these ciliary body membranes. It also allows us to remove some of these membranes. So this was an eye with extensive peripheral membranes, and what you can do is you can visualize this area and how you can use a cutter to shave off and remove these membranes, which with a conventional system would have been absolutely impossible to assess. So you can see the ciliary body and you can see some of these membranes which can be dissected over here. This was another eye with extensive ciliary body membranes, gross hypotony. This was the only seeing eye of this patient which had a vision of PL plus, the other eye was no PL. And when we went inside, we saw these extensive membranes all throughout the ciliary body. Also, later on, you will be able to visualize an IOL, which can be appreciated later on. And along the IOL, there were also membranes. So with the help of a forceps and scissor, what we were able to do in this eye was we were able to remove most of these membranes. Subsequently, we did a vitrectomy and ended up putting oil inside the eye. And we were able to actually at the end of the surgery achieve at least an ambulatory vision. This patient from PL plus now has a vision of counting fingers 2 meters in a silicone oil filled globe. But for a patient who had actually no vision, counting finger 2 meters of a vision also can be a bit of a blessing. So what this approach allowed us was to go inside, assess the ciliary body membranes, try to remove as much of them as possible, which otherwise with a conventional system would have been more difficult. So in eyes with a persisting hypotony, and Dr. Sangeet Mittal is here and he will probably be dealing with the topic of hypotony in uveitis. But what endoscopy now allows us is, it allows us to intervene in these eyes and visualize what's happening. So that's how intervention can be done with the help of endoscope. I'll just show you one more thing. So this was another of our patients, and this patient had a chronic recurrent episode of inflammation which was coming again and again. And when we went ahead and checked what's happening in the angle of this patient, what we found to our surprise, and this is how an endoscope can also help us in visualizing and assessing the angle of the eye, and we found subsequently that this patient had an occult foreign body, which was initially not assessed and realized. So this patient had a glass foreign body, which was the cause for recurrent episodes of infection that were happening in this patient. And we were subsequently able to remove this. So that's how, I'll just show you one very small video again, which is not something which we commonly do, but which also highlights how sometimes endoscopy can be such a valuable tool. So this was a patient who had actually come to our cornea clinic with a toxic keratitis. This patient had a bee stinger injury. And because of the extensive corneal edema, our cornea colleagues were not able to remove the stinger. And what they did was, this patient was having repeated episodes of corneal edema, toxic keratitis. And if you can see over here, so what we did was that instead of going ahead and trying to remove it superficially, because the stinger was embedded deep into the stroma. So I'll just show you what we did in this case for the interest of time. What we did was we went inside with an endoscope to visualize what is happening. And I think we've come to the previous slide. Just a second, please. So we were able to go inside, and subsequently what we found was, when we went and visualized the angle, was that we were able to visualize the stinger over here, which was deeply embedded. And then from the other side, we just made one more entry, got inside the eye. This is, we are deepening the angle with the help of a viscoelastic. And endoscope again beautifully allows us to visualize these angles. So the idea over here, the reason I'm showing is that sites which were earlier not accessible to us can now be visualized with the help of an endoscope. And subsequently we just went with the forceps, grasped the stinger subsequently and just brought it out. So this was the stinger which was causing all of this toxic keratitis, and we just could grasp it from the other side and bring it outside. was what? So in a nutshell, I will just sum it up by saying that see, endoscopy is an important modality that allows us to overcome challenges presented by anterior segment opacifications, allows for early VR interventions, and also management of ciliary body membranes and in tackling hypotony. Thank you so much.
Thank you, Mudit. You make it look very simple, though I know it's not all that simple to do an endoscopic vitrectomy. I have been really trying hard to learn it, but still struggling with it. I was just wondering that when we are trying to remove these ciliary membranes, majority of the time we actually land up doing a bimanual because they are in between the ciliary processes, and if you touch the ciliary process, they heavily bleed.
They heavily bleed.
So
what you can also do is instead of trying to peel it off or trying to remove it en toto, the fact is that the reason they are causing a hypotony is because they are contracting, causing traction, and in the process creating dialysis. So while if you try to pull or remove all of them, it will cause bleeding, like what you said, ma'am. So you can do is you can go with a cutter or with a scissor and then truncate them into multiple planes.
but with an endoscope, because you are having the camera in your light source only.
Yeah. So with one hand you have got your endoscope and light source with the help of which you can visualize what's happening on the screen. With the other hand you go with a scissor and then
just
you
snip
go
it
and
off.
cut all of those under visualization.
Right.
So that way it helps. So you can truncate them easily.
Any questions from the audience? Thank you. Thank